carry us for a full hour, although we don't necessarily need to cover a full hour if we don't need to, but it's intended to invite you all into the conversation to ask about whatever might be on your mind. And as these conferences are, if they're pre-patterned with a lot of material, we hear a lot of the same information over and over. We're trying to explore some other areas that you might be curious about that you haven't heard about previously, so please partake. So quickly, just to set this up, and then we'll give some introductions. Our panel is made up of somewhat of a diverse set here. So on my left immediately is Charles Black. He's out of CBRE, their Global Innovation Lead, really has a good handle on a number of sectors, but also healthcare related. And then in the middle is Stephen Stubbs. He's in charge of real estate with Adventist Health, which is a large system on the West Coast and Pacific Northwest. And on the end is Bob Riley, who's the CFO of Anne Arundel out of Annapolis. And so very different takes from all three of them. And again, I'll let them give a quick introduction each. They can tell you a little bit about their organizations, what their roles are, and then we'll get going with some of the material here. So Charles, if you'd like to get us started.
Absolutely.
Please go ahead.
And just wait till your Hawkeyes get a hold of the SEC. We're going to take you guys down.
We hear it every year.
So Charles Black, I've been with CBRE 10 years. I've had a variety of roles, whether on the development side, the consulting side, helped run some of our really big outsourcing type accounts. And specifically in relation to this conference, have a history of utilizing data and analytics to really help drive strategies to fuel the core business of a lot of our clients and partner organizations. So a team member and I invented our healthcare analytics platform. We invented our retail analytics platform, which are now global consulting platforms for CBRE. And I think a number of individuals in this room have actually seen that product and utilized this in the past. And in particular to my new role, looking for additional ways to drive innovation and strategy to, again, help fuel that core business of our clients and help grow CBRE as a whole. So thank you for letting me be here and looking forward to the discussion.
My name is Stephen Stubbs. I'm the Regional Director of Mergers and Acquisitions for Adventist Health. We're a 20-hospital system on the West Coast, and we have about 150 clinics. We're the largest rural health care provider in the state of California. Right now, I work in the Southern California market, and our growth mode is in the urgent cares, off-site clinics. So we probably have, in the next 2 years, we'll probably have about 5 projects going on.
Good morning, I'm Bob Riley. I'm from Annapolis, Maryland, and our single hospital independent system there in Maryland. We're the 3rd busiest hospital in Maryland, behind the gorillas of Hopkins and University of Maryland. We're about a $650 million organization and continuing to be aggressively growing into the community through our population health initiatives, and looking forward to the discussion today as we talk about growth and out in the community.
All right, thank you, gentlemen. So just to get started, I'd like to talk a bit about the data analytics piece. That's a lot of what this conference is about. It's certainly changing the mold in terms of the decision-making process from a lot of our clients in the healthcare sector, all the users. It used to be much more of an anecdotal-based evidence model where you were hoping that you were making the right decision. Certainly transitioning more to a database model with more empirical data that is validating a lot of those decisions. But the data platforms are relatively new, as Charles can assert to. And so, Charles, I'd like to hear a little bit from you, just a little more on, just a couple of minutes on how that data is being intertwined in the decision-making process from a qualitative aspect, if you're able to measure impact with any of your clients as of yet, and what they're seeing in terms of deliverables as it relates to market share.
Yeah, absolutely. Great question. And I'll kind of start at the beginning of kind of our journey. So any really hard healthcare questions, I'm going to push this direction because I'm not a healthcare guy. We actually started out in the retail space and started building models because we had a lot of our clients coming to us and saying, hey, we're spending about 70% of our time debating strategies at kind of a political level. And I feel like if we start leveraging data and analytics more, we can short circuit that and get to a point where we start with facts, and then we can layer that local market intelligence, internal political type factors on top of it. So we actually started out in the retail space by figuring out, well, CBRE, we're all about executing real estate transactions and deals, and when our clients don't have complete confidence in their strategies and where they're going, that's not a good thing for us. So how can we help our clients become more strategic, more confident, more empowered in their strategies, and do that in a way that brings a whole lot of science to a sector, as Josh mentioned, that really hasn't had a lot of science and data and analytics infused in it in the past. Now, with that said, and I'm gonna directly hit your point, your question, but with that said, 3-4 years ago, we had a health system, probably one of our first health systems, come to us and say, hey, we're looking to go in this direction in the market. I just don't know if it's the right direction. Our CEO's saying he likes this area. Our C-suite's saying they like these areas. There's a lot of internal turmoil. We want some help around, is this the right way to go from kind of a third-party perspective? Yesterday, I was on the phone, and a CEO of a major system asked the exact same question. So the questions haven't changed in almost 4 years. A lot of the systems are still struggling heavily with these questions and getting this fact-based methodology infused into their strategies. So specifically, Josh, to your point, it's been a long journey. For our clients that we've worked with for many years now, we have had a great opportunity to test a lot of the results. We had one client that had big market share in one market. We tested it. We came up with 94, 96% accuracy on the data that we were infusing in. We rely heavily on some data partners on making sure that accuracy is there. And then we also test by essentially saying, if we're going to predict something, how do we know it's going to be accurate? Well, the best way to test that is if you can predict current performance of existing locations to a certain level of confidence, you're going to be equally as confident in your future predictions as well. So we've attempted to build the best, most scientific crystal ball, more or less, of how do we predict if you make a change in your portfolio, a closure, a relocation, a new investment in a certain area, how do you predict that's going to pay off? How do you predict the population is going to be reached? And how do you predict it's going to be a success that you can build on in the future? Does that answer the question sufficiently? I know it was a long-winded answer, but
Well, it's challenging because the validation's still coming,
absolutely.
which is part of what's going to be interesting to see over the next couple of years. But so Stephen, kind of on the same vein, you mentioned the 5 projects that are coming up. I know that you've recently started exploring this type of data package. How is it being used inside of your system? What are you seeing? And did you see something different with this upcoming pipeline of projects that perhaps changed the ways you've been making decisions in the past, right?
It
Comparatively.
will. It will. You know, what you mentioned is exactly true as far as the anecdotal data. Just the last couple of weeks, I sat in meetings where I have a CFO, I have the Vice President of Business Development, and I have our CEO all providing directions on where they want to expand and build a new clinic. And those 3 areas are all 3 different areas, and it's based on their personal experience and what their doctors are saying, what some of the constituency is saying, what some of the investors are saying. So it was all opinions. So we're just starting out looking at, you know, the database that's out there. And the hospital systems, we're very good at looking at our inpatient, because there's plenty of data that is there for inpatient programs, inpatient projects, and how we're going to expand our inpatient focus. But nothing really out there on how we're going to expand into the marketplace, and especially with the focus in the retailization of healthcare. It's something that we're not very good at, so we need a partner such as CBRE or some of the other providers out there who have that experience in the retail marketplace and who can direct us to say, exactly, here are the points that you need to be. This is the future of where you need to go. Because we've been very focused on the mothership. And one of the strategies that we're taking a look at for the future is to say, maybe we need to take a look at what the community need is and focus and make sure the profitability of those individual sites are good, rather than having to say that, well, even if an off-site loses $2 or $3 million a year, it's not a big deal because we'll make it back on the referrals that we get back from the hospital. Sometimes that's not a very good strategy, long-term strategy. So we really need somebody's help to say, it's like, what's definitively the best marketplace to be in to serve the needs of that community, because we want to be there in the future, because that's where the future is going.
So to carry a little further, since we have a room full of investors, developers primarily, if you were in their shoes and you were looking at investments right now and trying to understand which of those have the best opportunity for success, if you you had to nail it down to 2 or 3 primary criteria that you think are the most indicative, what would you say those are?
As far as what our projects are?
As far as either an investment in an existing asset or a future asset, but one
Oh.
that's going to retain market share and be a viable asset long-term.
Undoubtedly future assets. I mean, I'm from Los Angeles, very fragmented marketplace, a lot of competition that's out there. So what may be true in Los Angeles, not necessarily say is true in other marketplaces. As I mentioned, is that we operate in the rural setting, and for those, we're buying old assets and they need a lot of refurbishment. So it depends. That's the conversation you're going to have with the CFO. If they're in a rural setting, definitely growth mode. The urban setting is definitely growth mode. In the rural setting, it's more, because not much growth has happened out there. They're operating, we have a lot of old hospitals that were built in the 50s, 60s. We've acquired them, so we need help in refurbishing those and getting them up to a better standard. And we're also, too, looking at acquisitions. Currently, right now, we're at NDAs with 2 systems to purchase them. So that's the other one. I would say, so to kind of focus it, is that it's definitely new projects, but not MOBs. But so it's new clinic projects, it's redevelopment, and then it's health system acquisitions and helping them. Because a lot of those health systems that are looking for acquisitions, typically because they're having challenges with their capital, and that's one such system we're working with now, is that they've looked to us to basically save their new expansion project.
So you mentioned we should talk to the CFO.
Yeah.
So let's talk to Bob. What are your thoughts? And actually, you're kind of getting into capital cycles as well there for a second, Stephen, which is somewhere I'd like to go in a minute.
Sure.
But on the strategy of outpatient clinics, I know Adventist or Adventist? I can never remember exactly. What's the appropriate
Either
way to
one
say it?
works. So I'm Seventh-day Adventist, so we always say Adventist. Yep.
Got it, thank you. So Bob, from perspective of a small hospital that has the luxury of being in probably the best payer mix in the States,
Yeah.
what's your strategy as it pertains to assets right now? Kind of along the same lines as I was asking Stephen. What are you all looking at when it comes to your real estate assets? What's your confidence level in the deployment of capital within those? And more or less, what are the service lines that you're really focusing on primarily in the outpatient setting now?
So to give some context, we have 7 medical office buildings, coincidentally a commercial office building. The medical office buildings, 3 are owned, 2 are master leased, 2 are partnered with, one with physicians, one with Hopkins Health System. And we're continuing to grow into the communities to try to create access, try to live up to the triple aim of the PPACA, and try to understand what's the needs of the patients out in the communities. In Maryland, reimbursement's a little bit different. The only reason I mention that is because our focus is really to reduce unnecessary care in the hospitals, and for that we're rewarded. And for that, we keep the dollars in the operating margin and are able to reinvest in infrastructure out in the community. As we reduce that unnecessary care, obviously that creates capacity within the hospital, so we're focused at how do we put good care back in the hospital, solid surgeries, not elective type of work back in the mothership, if you will. But in order to create that, to reduce that unnecessary care, we're putting infrastructure in the communities, primarily in either leasing or single-story, smaller, 20,000 square foot, multi-specialty type of facilities. We're considering, we're financially pretty sound organization and can afford to build and own if we wanted to, but quite frankly, we want to be able to leverage opportunities with partners, whether it be the physicians, whether it be investors, whether it be other health systems, other community agencies, state and other local agencies, to partner in a community to provide either just chronic, normal primary care services, some smattering of specialties in those satellite facilities. Certainly are considering ASCs In Maryland, there hasn't been a lot of hospital development of ambulatory surgery centers by the hospitals themselves. There's certainly a lot of independent surgery centers, primarily owned by the surgeons themselves, and kind of pulling back from them and competing with them obviously becomes a challenge, particularly if they're doing inpatient surgeries in your organization, and you might be stealing some of their revenues from their outpatient surgeries. But we are considering that. Those could be co-located with those multi-specialty centers. Certainly, imaging is a big need, and also as a revenue generator for us outside of the hospital. It's a natural fit with both the primary care and the specialties, and certainly urgent care. And we are doing some development with some of the local grocery stores chains with immediate care. So similar to a Walmart kind of thing with a nurse practitioner model. We're doing some of that. We're again, trying to understand what's the best financial model for those. We understand, like Stephen said, that some of those might be lost leaders to a certain extent, but it also creates access points and potential downstream revenue for good revenue and necessary care for the hospital, while also extending the care after an acute care episode so that the patients have access to primary care or others, keeping that readmission out of our organization, which is a bad thing for hospitals nowadays across the country.
So on that last piece you were talking about, you're more or less getting into episodic care, is what you were talking about there at the end. So I'm curious to hear a little bit more about your strategy, especially because you're in a true population health market. Is your urgent care strategy, would you say it's more based on belief that you can actually generate downstream revenue, or is it more based on cost avoidance because of the data that you're getting from the population that you might not otherwise get?
So as Stephen said, we're facing the same thing. Most hospitals in Maryland, there's 46 hospitals in Maryland. We have a lot of good inpatient data, very little outpatient data. So you have an episode in our organization, we know what your payer, what your insurance company yourselves paid for that care. Don't know very little about the care afterwards. Did you go to your follow-up visits that are necessary? Did you know what drugs did you take? Or did you order those properly? Did you go to your rehab? So forth and so on. And for the older adults, how long did you stay in the SNF? What was the care there? Why did you wind up back in our ED because of what issues, what caused that? Those kinds of things. The data is not really available for that easily. We can get to some of it. Payers are reluctant to share that information. But our strategy really is to try to begin to bridge. We're an Epic hospital for clinical platforms, and we're trying to extend that into the community, both not only in our employed physician population, but also access through other primary care and urgent care providers in the region, so that we can have a seamless transition of patients both from the hospital out into the community and vice versa. If your patient shows up in our ED, we want to understand that. We do about 93,000 ED visits a year, pretty busy ED, and I would say probably a third of those aren't necessary. From a clinical standpoint, people didn't want to come in, didn't want to wait till the next morning for their primary care to make the phone call. They weren't aware about the urgent care availability, numerous reasons. And so we're trying to unload some of that unnecessary care in the ED and put it in the proper, accessible, cost-efficient, low-cost provider, quality care provider situation for the patient. Ultimately, we want them to be able to connect with those folks after the care anyway. And so we're trying to build that infrastructure relative, to that, and the connectivity through our electronic records, and then beginning to partner with some of the existing providers, SNFs and others in the area, as well as beginning to develop our own.
So I want to stay on the line of episodic care just for
Yep,
another
yep,
second.
yep,
So-
sorry.
So, no, it's okay. No, I'm not chastising you for talking about other items. That's fine. I was actually going to ask Stephen, so I don't recall whether you all are partnered with a retailer, a big box retailer or not, but with obviously the big leap that big box retail has made into the urgent care setting, these convenient care clinics, I'm trying to get a better understanding of what the system strategy is around the true episodic care base. Similar question I was asking Bob, is the investment actually providing downstream revenue, and/or is it preventing major costs in the future by gathering data on patients that might not otherwise come in? What's your strategy at Adventist?
So it's a portion of both. And I did earlier say that, we're really trying to focus on what the need is of the community when we go out to the marketplace. So we may not consider the downstream revenue. It's still important, so don't get me wrong there. It's just not necessarily the focus. As far as the partnerships with some of the retail medicine and the big box providers out there, it's really a different level of care they provide. It's really medication management. So what we're looking to do is actually, at our urgent cares, is twofold. One, to necessarily kind of compete a little bit, not get into their marketplace per se, but to say that, we can do that at a higher quality level because we have the providers, we have the experience, we have the systems, so we do know how to do that. But on the other side, too, to keep them out of the acute care setting is to, along with that medication management when they present, is to see if we can avoid the readmission rate. So when the patient is discharged from the hospital, we can send them to our urgent cares and have their medication management there and have regular follow-up visits that are scheduled follow-up visits within that for a lot of so that those patients are discharged, but also too, the chronic patients for them. So it just helps. So that's the model that we're looking at. We're acting strategically. So hopefully that answers the question as far as we're looking at the retail marketplace. But we do that primarily because we are very cognizant of the quality of care that we can provide, and we want to make sure in our environment that we can control that quality.
So was that a diplomatic way of saying that the retailers don't know what they're doing?
No, it's just a different avenue. So it still provides service, and we actually appreciate it when they open up in our marketplace. It's just that there again is that because of our insurance rates and our risk management, but we also see it as a potential.
Sure.
So it's not to say that they don't do a good job. It's just that we feel that we can do the same thing.
So Charles, expanding on that, and actually we can get into some other service lines too. One question I had for you, and I don't know how much you can share, but based on the number of searches that you all are doing, do there tend to be specific outpatient service lines that are in high focus right now across most regions that you seem to see over and over within your group?
Yeah, I mean, for outpatient in particular, we started out heavy on freestanding EDs. We've seen that drop a little bit over the last 2 years, probably in terms of need. Urgent care was certainly toward the top, but primary care is a majority of our emphasis. Where do we anchor primary care and support that with urgent care, but then use that to A, serve a majority of the patient needs that are out in the population, but B, also refer them back into the hospital when needed, to these guys' points of making sure you're actually doing the right procedures in the hospital setting. So we are seeing a majority within primary care. Now, you mentioned about kind of competitive threats and the retailer perspective. It's interesting as you go across the country, in California, obviously Kaiser is top of mind for just about everyone, and they're doing video conferencing and not even needing real estate for a lot of things. When you go to Illinois, they're talking about how Walgreens is impacting the way they're doing it. When you go to North Carolina, they're not worried about the retailers much. So it's interesting how it varies based on the populations and the individual states and other factors. But and I think overall the sophistication of the systems we work with varies heavily as well, and some are more cognizant of the impact and others aren't. So it's just interesting to see the diversity around the concern and the way they're addressing that concern state by state.
So have you all formulated an opinion on whether retailers are a threat? Or are those partnerships actually accretive in terms of, well, maybe accretive is not the right word, but are they beneficial, if you will, to certain systems? Are we seeing that there's a major benefit there? Are they detrimental? I mean, what's the opinion within your group?
Yeah, I mean, I'd love to get everyone's opinion, but from our standpoint, we are relying heavily on our clients to tell us that answer. So we ask the question on the front end, what is your strategic plan? What are your objectives? We're then going to create a strategy specifically to hit those objectives. The majority of our clients that we work with today believe that the services that are being provided are more complementary than competitive by those retailers. And they're services that the systems themselves don't necessarily want to perform, and they're not making a lot of money off it. At the same time, they are weary that it is the entrance point sometimes for those patients into the systems, and they want to make sure they don't lose that entry point and that opening conversation. So I think it's both sides of the equation, but for our analysis, I mean, the best way to gauge it is how much are you actually factoring in retailers into the strategies and the impact of those retailers, and less than 10% of our clients desire to actually do that. So that tells me they know the threat is there, they understand it, they see it both as complementary and competitive, but at this point in time, they're not willing to factor it in heavily and allow it to sway the way that they're approaching their markets.
Yeah, I would agree with Charles. I mean, you just said it much more eloquently than I did. So, I mean, case in point is that, we know it's there. It's just, don't know what to do with it right now.
Yeah.
And I would say that from our perspective, at least in the Maryland marketplace, while in certain ways there's competition, I think depending on the referral patterns from a retailer to back to the mothership, I think that the relationships are what's important there, and we are concerned about quality of care and customer satisfaction, and if our name happens to be associated with certain retail options, we want to make sure that because it comes back to us. I mean, in terms of the customer satisfaction, patient satisfaction, ultimately, but we're not really concerned. Again, it's about creating access right now, and so I think it's really we're working on relationships with independents and others, as well as trying to deploy some of our own strategies where we see gaps in the region for coverage, which we get through a variety of sources on the data analytics side of things.
So Charles, you talked about a large degree of attention paid to the primary care deployment, which has obviously been going on for years, which tied up with also obviously all the acquisitions of those physicians. Bob, you mentioned you're doing several 20,000-foot clinics kind of spread throughout. Stephen, I haven't heard too much from you on what types of projects you were doing. Are those consistent with the strategies, with the projects that are currently within your pipeline as well? Are they primary care based? Are they smaller facilities spread throughout? I mean, what are you really all focused on?
So for our Southern California market, we're really focused on primary care clinics and urgent cares. So the two projects I mentioned are primary care clinics, have two urgent cares that will come online in 2016, and then we have a specialty care clinic that we're looking at too. So those are anywhere between 2,500 to 6,000 square feet, smaller projects.
Sure.
Throughout our system, we've got 2 medical office buildings going on. Our Portland market is primarily heavily clinic-based, so they're always expanding in the clinic area. And in Central California, same thing. It's basically, as I mentioned, redevelopment of old assets, and then new clinics out there.
So what opportunities are on the horizon for other service lines? Where's your primary attention paid outside of primary care, maybe in the specialty platforms? Are there any hot items other than ortho that you might have a lot of focus on currently?
The other one would be ASCs, I think. But ASCs, to a certain extent, it really depends, and that's there again, the conversation with the CFO. Because depending on the marketplace, it's really, there's a lot of data analytics that need to go into an ASC, because ASCs can live and die based on the demand. So you can put up an ASC today, and it'll be wildly successful, and you could go 20 miles down the road, and an ASC will fail miserably. So it just depends really on, what the drivers are in the marketplace and what the competition is, and what the referral patterns of the physicians, the relationship with the physicians. So if there's any complex model out there, if you're looking to do an expansion on, it's the ASC, because it is so high risk.
Yeah, and I'll add on to that. We probably have 3 or 4 clients at the most at this point that have dove into ASCs heavily. Our data provider is actually, as of March, started to release specific ASC data. I think we actually triggered that for them, so I'm glad we brought a new product line for them. But we are diving heavily, to Stephen's point, around, all right, we know you're looking at ASC, but what does that really mean? What services do you really want to provide, and which ones will be profitable? And breaking it down to, in some cases, 30 different potential procedure types that will be performed within that facility, breaking that down and understanding what's the demand for each one of those, how is the rates and reimbursements and other things change for each one, how does payer mix affect each one, and then building that back up to a business case at the end of the day. So we've seen success and actually seen a lot of diversity in just the definition of what they're looking to accomplish through an ASC, but breaking it down, to Stephen's point, and making sure the population is there, and the demand side for each one of those individual procedures is there before you dive in is key.
Yeah, I think if there's any project that is fairly easy to decide and determine that it's going to be profitable going on, Bob, get your opinion, is imaging centers. Depends on the marketplace there again, but I think it's a little less risky for a healthcare system to get into than ASC.
Except that they're very capital intensive, depending on what you're going to put out there, and most people want an MRI, and most people come in and doctors now, while there's a lot of pressure on doctors to reduce the use of certain imaging procedures, there's still a high demand for MRIs, and they're still pretty expensive, and the technology continues to improve every year, and of course, docs want the latest and greatest thing. So, yeah, but it is, you certainly, if you've, as we have tried to do in satellite settings, if you have the right mix of physicians, either employed or partnered physicians, that have referral patterns to you, you can certainly support on a profitable basis. And, our imaging centers, we have 7 independent, they're owned, but off-campus imaging centers, and they're doing about 22 or 3% for us. We think that's a pretty good margin. But certainly the ASCs, I think, are a little bit riskier. And I think the dynamic that I mentioned earlier of partnering with the surgeons who would be doing the work there. Now, certainly, if as the evolution of surgery changes and every day length of stays drop for inpatient surgeries, things shift from inpatient to outpatient surgeries. We're down in our organization to 1-day length of stays for hips and knees. Before you know it, there are some orthopedic surgeries that are going on. I'm talking implants outside of the hospital, depending on the health of the patient. But as those continue to evolve, and patients want, easier access to those locations, cheaper, same quality level, of course, the expectation is there. But as those things continue to evolve, it's, we're treading on partner physician territory, and it's a balance of maintaining the relationship with those independent surgeons and still trying to make sure that you're delivering the lowest cost of care out there in the place where those patients want to go. So you do have that risk beyond just the financial risk, and certainly the implications of the former imply potential financial losses for the latter, building an ASC without support of the physicians.
So you mentioned something about the capital appetite and capital of cost of certain facilities. Hilda mentioned a metric this morning that the age of infrastructure across a lot of the country, I think a significant majority of assets were built before the year 2000. Stephen, you were talking a lot about investment into existing assets and refurbishment because they need to be newer, more, whether it's state-of-the-art or just more appealing in terms of the experience for the patient. How are you both dealing with the appetite for capital as it relates to real estate in the environment of increased technology costs, a very healthy M&A activity, whether it's physician-related or hospital-related? How is that impacting your capital cycles and some of the conversations that you're having within your finance departments?
I'll take that first, I guess. So we have a rolling 5-year capital cycle, a 10-year strategic plan with 3-year increments that are updated every year. And I think we have 38 goals under 5 pillars of areas this year and strategic goals. In terms of funding, both operationally and capital-wise, those strategic goals and our appetite to continue to expand our footprint, not only pushing the boundaries out, but also filling in the gaps for care. It's a balance because, we have the luxury in Annapolis to have built a new hospital in 2001. We've done some expansions to it. And the technology that there is, the docs, while they're extremely loyal, they demand the latest technology. So there's a balance between normal technology, equipment, so forth and so on, and the real estate expansion. And we've kind of divided our capital cycle into, whether it be IS or medical, surgical technology, and strategic development, both on the capital side, building out buildings versus leasing and lease TI costs and so forth. So, we've tried to, we think some of it is still maturing, some of it's anecdotally, some of it is based on data that's disjointed but pulled together by strategic planning folks, and trying to deliver a plan that we can fund appropriately on an annual basis. But I would say there's not much funding of capital in rates in hospital reimbursement, and so we have to be judicious about that.
I think, for the interest of the audience is, it's twofold. It's a conversation on the growth side with the business development people, but then it's back to the CFO on the infrastructure. At least for Adventist Health, we really try to balance it. Our focus, we are in a growth mode, but at the end of the day, our focus still is very much on quality. So we try to balance to make sure that any of the growth strategies have a revenue attached to it. So we're not so eager to go out and say we're willing to have a project lose money because of the resultant downstream revenue. We really want to make sure that that project can stand alone on itself. And on the infrastructure side, it's back to the reinvestment of quality to the community. We want to make sure that we can give them that experience in the hospital, so there is infrastructure development going on. So it's, I hope that answers your question. So it's really 50-50 with us as far as what we're looking for in the future.
Okay. Well, we don't have too much time left. I know got a late start, but I wanted to open up for questions if there are any.
Yes. I heard a number of good things. I had a question about.
There's a push to talk in your microphone, by the way. It might help out.
How's that?
That's perfect. Thank you.
Heard 2 things that may be in conflict or may be complementary, and I wonder if you could speak to that. One is the sort of the need to increase the hospital alignment with primary care physicians, which sounds like convenience and accessibility to patients. And the other one was multi-specialty clinics, where you're transitioning some of the services out of the traditional hospital space. You're getting synergies and economies in those locations. Are these two, so one seems to be a little more dispersed out there, and then another one seems to be, maybe sort of regional centers within a metro area. Are these two ideas in conflict with one another, or are they complementary to one another, or if you could speak to that?
Go ahead. Well, for our marketplace and for most of our marketplaces, there's just such a heavy need. If you look at the analytics, there's such a heavy need for primary care. Last 10 years, we've been really focused on recruiting specialists. Now we're in a place, especially in cardiology, where we have too many specialists. We have too many cardiologists in a particular marketplace. So we're cooling off that strategy for us, at least in California, really focused on primary care. And a lot of that has to do with the Accountable Care Act, because those traditionally uninsured patients now have some money. And so a lot of those primary care physicians are more eager to take the Medicaid patients. And one of the driving factors for us that's really created some upending in the marketplace is that the wages of primary care physicians has almost doubled. Traditionally, we would pay in the California market, primary care is about $150,000. I had some data that a primary care in San Francisco market was making $330,000. So it's really changed, it's really evolved. So case in point is that the competition is so tight for the primaries as far as driving the marketplace, driving the care. They're going to be our partners in the future to both manage the patient on the inpatient side and the outpatient side. So we're heavily focused in the primary cares and just making sure that they are stable and can help us out in the future.
Yeah, and I would say to your question too, I would consider complementary actually. I mean, we're in Maryland, physician reimbursement's not that great. Partnering with, and we don't, the 90s and acquisition of primary care is kind of beyond. It's more of employment models. But there are other partnership models with primary care that we're trying to do. I know Stephen's doing some IPA stuff out in California. We're trying to start up some things in our own state where there's opportunities for combined contracting for payers and try to improve that. But there's because there's the cost of living, the reimbursement rates, even though we enjoy 2 great medical schools in Maryland, they're not graduating many primary care that stay in the state. And so the existing primary care physicians out there are at a premium, if you will, and you're trying to build those relationships. In our particular marketplace, the primary cares are still very entrepreneurial. They're of a generation that wants to maintain their independence. And we see the multi-specialty satellites as complementary to and creating access for those primary care physicians and their patients in easier locations, and having the ability to deliver a numerous one-stop shopping kind of concept, a Kaiser model, if you will, in certain regards, for those primary care physicians to refer to both during the day and after hours, quite frankly, to support them in their trying to be a normal life and still deliver care to their patients.
I guess maybe the thought I had was, or the question I had was, in these multi-specialty clinics, how much of the occupancy of those clinics are primary care docs? Are you consolidating and relocating them into multi-specialty clinics to any degree, and or are you leaving them kind of where they are and then filling up the multi-specialty clinics really with these other specialty services and the diagnostic services that just might have been in the hospital in previous years?
Yeah, great question. So I think it depends on the analysis of the location and the area and the geographic region. We're looking, so Annapolis, 30 miles, 40 miles east of DC, right on the Chesapeake Bay. We're looking across the bay, and this one of our 20,000-foot spaces. We don't see necessarily putting primary care in there because we have some primary care deployed around that site. We see bringing in some specialties. When I say primary care, I do include OB, but we're also talking about putting OB in that particular site. So depending on how entrenched the primary care, either independent or employed physicians are in their current locations, how disruptive it would be to move, what's the distance of the move, what does it mean to their patients, what are their thoughts or feelings about it. We need their buy-in to move them, just pick them up and move them, and how disruptive they think it might be really drives whether or not we combine them in that multi-specialty center, or whether it's really truly specialist or other, complementary services, whether it be PT, whether it be imaging, whether it be whatever.
Yeah,
Go ahead.
and Jay, great question. And the only thing I'll add is at least what we're seeing, they're all very convenience-oriented. The level of sensitivity to convenience is what really varies. And Jay, you've lived with this, with us through this many a time, but especially to Bob's point, if there's a lot of primary care surrounding, typically they'll go multi-specialty in the hub. That kind of takes, all right, I know my sensitivity to neurosurgery is very low. My sensitivity to urgent care is very high. How do we look at all of those combined into a multi-specialty area, take the average of them all and figure out what's the point within the market that's most convenient for all of those procedures at once. And then if there's a lot of primary care surrounding it, usually you won't move it. If there isn't, just based on sheer volumes, usually our clients end up putting some primary care in those clinics, just because, I mean, you look at those specialties, they're down in the 2, 3, 5, 10% of the same kind of volume range. So sometimes you have to have it to anchor and justify the investment as well. But it heavily depends on the network. But just wanted to note, each one of them, their sensitivity levels vary a lot from one procedure group to the next, and factoring that in is a really key component.
So I'm going to field one more question, and then because of my poor planning, not expecting it to run over, I'm going to have to duck out and head out to the airport. But Stephen and Bob, you'll be on your own. Which I know Charles has about the same time I do at noon, so we've got to head out. But right over here to the left of Bob, go ahead.
Yeah, I've got a quick question, or I'm asking for observations from all of you. I guess in August, they announced that Providence and Walgreens formed a partnership in Oregon and in Washington, and they're going to operate 25 stores over the next 2 years in those marketplaces. And just thinking about Walgreens' footprint alone of 8,300 stores, do you think that this is going to gain traction, or this is viable? And what do you think the positives and the negatives are for embarking on a partnership with someone like Walgreens?
It depends on the marketplace, and if the community knows that Walgreens is a place where they can receive their care, then I think that works. In our marketplace in Los Angeles, we have traditionally a lot of independent providers. A lot of those independent providers have had the same patients for 30 to 40 years. So it's back to my previous comment about where the healthcare system in Los Angeles has been so physician and hospital driven that the Walgreens of the world really haven't been able to gain much of a foothold, or the CVSs, in the Los Angeles market. Now, that could be different in other markets. So for us, it's not a viable, I'm not sure that they may look at that as a pretty tough marketplace to enter into. But I would agree, as far as the future and where it's going, if the community is supportive of it, then yeah, I think it will continue throughout the United States.
Yeah, so I think the major concern about picking a partner is, and if your name's associated with them, is that view of the quality care, and how is it going to be delivered. Most of those types of clinics are more immediate care than they are urgent care. And what we've seen, and we have 3 of them going now, with another 2 to launch, is that they're predominantly younger patients. They're not and they're an immediate access kind of need basis, whether they have a toothache or whether they have a physical, whether they have vaccines. So so it's not real complex care. One of the things we would like to see, as we have discussions, in fact, we have co-located a multi-specialty center next to a brand new Walmart, who actually has an immediate care in their facility. We didn't partner with them, but we have had discussions with them about referral patterns. So as our primary care or our specialist can recommend them for immediate care. We also have two in the same shopping center complex, two independent urgent care providers as well, and we've partnered with them to be referrals, to direct referrals as appropriate to the specialist there or to the mothership, if you will. It's more of a relationship and a strategy rather than a monetary, structure, financial structure, ownership or otherwise, because I think we can still coexist and deliver the care that we need to, and not have to own and control, except where if we're co-branding, then we want to have a little bit stronger legal bind, tie, whatever, to ensure the quality of care delivered there is to the standards that we need.
Other questions? I feel like I've been ignoring this side of the room since I looked that way.
Yeah.
All right, Bob,
Actually-
Stephen, you guys can thumb wrestle over who's in charge.
For Bob and Stephen, we've actually got a surgeon over here in Dr. Abraham, so hopefully we have more of those next year. Is it your interpretation of what's going on in the last 5 years, the homogenization of the healthcare industry? You reference entrepreneurial private practices. Private or independent private practice is a thing of the past. Is that history? And in your opinion, there's kind of this, I've seen this incessant need to grow in the market and grab market share. How do you balance that market psychology with quality care for the patients?
So in the Maryland marketplace, well, first of all, and as I said, in our area, our specific area, there's more private practice, and they're not necessarily interested unless they're really concerned about their income. And, quite frankly, most of the private practice primary care physicians are north of 45 and have already had their taste of ownership, and they don't necessarily want to give up. They view employment as kind of a loss of control, so, that generation. The newer primary care physicians coming out of med school seem to be much more concerned about their lifestyle, managing their lifestyle. I think it's kind of a healthier attitude, quite frankly, and they're not so much concerned about being employed, and they see opportunities for additional learning, additional growth in themselves by partnering with a larger organization. I think we talked last night about MedStar, which is the other large health system in our area. They've gone to a model where they're going to employ every one of the docs that comes, that does business with them. And so they're aggressively going out in the marketplace and doing that, both specialist and primary care. I do see we do see some consolidation in some of the specialties, urology, radiology, anesthesiology, some other things going on in the Maryland marketplace. Primary care, some large groups, but when you look at the dynamics of those groups, they're not really functioning very, very well. There's troubles, amongst their partners and so forth. But the consolidation that's gone on and the employment, they have a high tier ownership of that consolidated group, and then employed physicians that work for that group. So that model seems to work for some of the newer physicians coming out of school and not having to partner, not necessarily joining up with a hospital but there's a lot of pressure on the hospitals now to grab those either coming out of school, seed them with an existing employed primary care, or develop the relationships with the independent primary groups.
Yeah, I would agree with what Bob said. I would add, for California, we're a state where we cannot employ our physicians, so we do it through medical foundations. To answer your question directly as far as how that's going to affect care in the future, wouldn't we all like to know that? The only thing I'll point to is that during the 90s, a lot of the health systems had a big push towards acquiring practices. So everybody acquired practices, they bought practices, and then that fell apart. So we're kind of in that mode again to a certain extent. So, but I think there will be a shift. There is going to be a transition as far as the expectations of how care is delivered by those primaries. What's very tight is there's always, in the older generation, there's always, what we've seen is that there's a very tight relationship between the physician and the patient. So if you do have typically an employed model, sometimes you're going to be rotating those physicians through a lot, and that will sometimes affect not necessarily the actual quality of care. The actual quality of care may be better that they're going to get, but there's the perception that because I'm not seeing the same physician through going to your clinic where you have employed physicians, so they can have the quality of life. You know, physicians aren't going to be working 12 hours a day. They'll be working 8-hour shifts sometime. So what that's going to affect is that physician-patient relationship may not be traditionally as tight as it was in the past. So I think over time, I think that and the millennials will probably be okay with that. So as far as the quality of care, I would say it's actually going to get better, improve, because of technology is going to get better. With EMR, we'll be able to have better access. And how as we're trying to manage care to try to reduce the readmission of that patient, as I mentioned earlier, you know, having, once we discharge a patient, having them come back to the primary care setting where we can manage their medications, we can manage their care much better, we can manage their chronic conditions much better. So in the end, the quality of care will get much better. It's just, will the community, will their perception of quality be that it'll be the same?
Yeah. And there's penalties for not improving quality care,
Yeah.
so financial incentives not. Other questions? I'll count to 7 and.
Well, I would add one thing actually that may affect, you know, for this group and the future of real estate. So we have some projects going on for telemedicine, and so that in the next 10 or 15 years may actually kind of reduce the need for real estate because you won't have to build these clinics and employ them with specialist physicians because your specialist physician may be down in the city. Right now we have in our Central California market, it is in a lower income area, and it's very expensive to pay a specialist physician to sit at a clinic that may only see 4 or 5 patients a day. So we have a telemedicine program that routes back down to some of our specialists down in Los Angeles. So I think, you know, that it would be, as far as the evolution of what I've seen in the real estate conferences, it was heavy on medical office buildings development. Now we've gone to the ancillary care and urgent cares. I think in the next 2 or 3 years, the conversation is going to be about telemedicine and how that's going to be kind of a game changer in the marketplace.
Yeah. And I guess one of my final closing comments, shameless plug for Revista and their database. You know, really excited about the evolution of their database and the analytics that can come out of their database, and we're seeing some really great applicability in our markets. It's consolidated where we've had to fight for, you know, pieces of it for years and pay consultants to gather it up and put it, synthesize it, and so forth. So I'm really excited about the evolution of the Revista database.
Yeah, I would add the same too.
Shameless plug, sorry.
Yeah, no, but it's true.
No ownership.
That's where you can help hospitals. You know, is that we're very good, as we mentioned, very good in the inpatient setting, but in the outpatient setting, we need help. So bring data to the table. You know, tell us about our marketplace. Yeah. I think that's where you're going to get the business from.
And I think the evolution of the data, we talked about it yesterday for a while, is the predictability, you know, predictive analytics coming out of the data that, you know, so we know what it says, but what do we do with it and how do we use it and what's the trends and really what is, you know, what is it going to tell us to the direction to move in the future? Are we skating to the puck or are we skating away from the puck? Thank you all.
We have Revista data